to tell me exactly where you're from, that would be great. I'd love to see where people are coming from. Oh, good. Lots of you are typing. Yellowknife. Oh, amazing. Toronto, London, Hamilton, Winnipeg. This is very cool. Wow, Manitoba, Edmonton. Oh, look. Another person from Calgary. Hello, Caitlin. Lots of people from Calgary. This is awesome. New Brunswick, Port Hope, Ontario. Well, this is great. Okay, so thank you so much for sharing that and also letting me know that you're pretty comfortable using your chat box. We will be using this quite extensively throughout the webinar. I anticipate that this is going to be a way for us to come together across the country to really learn and speak with each other. So I just want to go over what our rights are as learners for this virtual space. So every single person that's participating right now, you have the right to participate, and so we can participate in a few different ways. You can use your chat box to ask questions. You can use your chat box to answer questions, and if you also look to the top screen, you'll see a little figure of a person. If you go down on that, you can actually click there, and you can see different things like raise hand, agree, disagree, speak louder, speak softer. These things will show up. And so I'd really like it if you can use those if you want some help, because I'll be paying attention to a couple of things. Also, please participate in our polls. We're going to ask you a couple of questions. That being said, if you're the type of person who comes to these webinars and you just really want to sit back and relax while you're eating your lunch or doing whatever you're doing, you do have the right to pass. When it comes to privacy in webinars, I just want to remind folks that it's really important that we don't type out any information that could be considered confidential about our clients or the folks that we work with, just because we will be getting into some scenarios, but make sure you're respecting everyone's right to confidentiality. I think respect is very interesting. You're clearly all very respectful professionals from a lot of different areas, and I'm sure you have a lot of experience. When it comes to respect, though, in the written format, I just would encourage people not to use cap locks. That is essentially yelling in typing. And just to be really mindful of what you're writing and how you're saying things so that we're all respectful of each other's different values and opinions. And the last thing is fun. I would really love for this little bit of time together to be fun and engaging, and for me to learn a lot of stuff from you. So what I want to do is, Rachel is going to help me right now by putting up our first poll. And so what I would like you to do is answer the poll by letting us know which professional group you most identifying as belonging to. And then we can kind of see who's in the room. Lots of nurses and public health folks, excellent. Policy people, what would we do without you policy folks? Some social workers, great. Excellent. I'll give people another maybe 35 seconds or so to type this in. Okay, wonderful. So it looks like we have a pretty interesting spread of folks who are working as nurses and public health, as social workers. So that's really great. Rachel, you can just put that poll away now. Thank you so much. I think what we have today is a lot of experienced folks, and so we can really join together to share some information. Okay, so what I want to do is for everybody to take a moment and just think about the word stigma. So it's a pretty big word, and I'm curious if people could try to just type out one sentence describing stigma, how would you describe it? And I'm going to give you a very short period of time. So this is almost like a typing test for people. Excellent. Lots of you are typing. I keep forgetting you can't see me, which is super bizarre, but I'm like really smiling and really excited about how much engagement's happening right now. Okay, great. So Gary's saying separation. I think that's good. Generalization, marginalization, negative judgment, shame, preconceived notions. Excellent. Okay, labeling. So clearly none of these things are excellent things to do, but I think the way you're describing it is really good. A set of negative value judgments against someone or something. Great. Just going to give Layla and Rosalind a minute to finish typing, and then we'll move on. Perception. Yeah, I think that's really great. Really important piece to bring to this. So one of the things that I'm noticing, just from looking at your definitions, is that negativity and deception, great, is that there isn't one clear definition. And we're also looking at stigma that's happening on many different levels. One of the things for myself that I think has been really cool in engaging with this in this process with the CPHA is recognizing that stigma is a lot more complicated and difficult to define. In fact, stigma occurs on many different levels. And so what the CPHA has done, which I think is super fantastic, is they've really hammered out a solid definition of stigma and the different ways in which it can manifest itself. So I would like everybody to take a look at the screen. I'm just going to go through these quite quickly. For the rest of the webinar, we're really going to be honing in on these specific areas of stigma and looking at interventions that we can take up as professionals to target these specific areas. So perceived stigma refers to an awareness of negative societal attitudes, fears, discrimination, and feelings of shame. Internalized stigma refers to an individual's acceptance of negative beliefs, views, and feelings towards the stigmatized group they belong to and oneself. Enacted stigma encompasses overt acts of discrimination, such as exclusion or acts of physical or emotional abuse. Acts may be within or beyond the purview of the law and may be attributable to an individual's real or perceived identity or membership to a stigmatized group. Layered or compounded stigma refers to a person holding more than one stigmatized identity. Sometimes when we talk about this, we also refer to the intersectionality of oppression. Institutional or structural stigma, the stigmatization of a group of people through the implementation of policies or procedures. So if you look back on your own definitions, what I think is really important is that as a group, we came up with all these different areas and levels of stigma. And so I think that looking at it and breaking it down in this way can be particularly helpful. So I'd like everybody to look at this really excellent, I would say like model of stigma for all of you visual folks out there. I find this really helpful. You can see how intersecting sources of stigma can really compound what happens for a person. And so what I'm going to do now is open it up again just for a little bit of texting or chatting. If people want to talk about what they think of when they see this. Do you think this is real in your practice? Can you see how stigma is quite related to racism and classism, gender inequalities, stigma related to STBBIs, sexuality, substance use? I'm just going to open up the chat. The one thing I want to say for folks is don't worry about your spelling or your grammar or your typing skills. I recognize that I'm asking you to do a lot of things at once. So a lot of people are saying that this model really does depict stigma very well. Oh, this is excellent. Very prevalent in harm reduction work, how our clients are treated at different facilities. I agree. I have a pretty long background in working within harm reduction. And I think when you talk to folks who are experiencing stigma, this is what they describe. Nicole has a really excellent comment about how I think people living in northern Saskatchewan won't go to their health care centers for care because of the stigma. And Dan is bringing up a really important point. Sometimes within families, we can see that this happens. What I personally love about this model is that it allows us to see how we need to be really directing our interventions and our strategies on many different levels. It's not just about working with the individual. We actually have to look at this from a macro level perspective and start targeting things, large things like racism, heteronormativity, classism, gender. How and where does this model intersect with professional obligations and codes of ethics? So Glenn, you've just asked a fantastic question. And what I would say is that with most professional code of ethics, we talk about the duty to do no harm. And so I believe very strongly that we have a professional obligation to target stigma through all of these different layers within our own professional practices, and that might mean advocating for change. So I love that, Glenn. That's a really important point. I think it's really important to what Sean is bringing up in terms of how we talk about people who are trans or non-binary And just the language that we use can create super major barriers for people accessing healthcare. And how actually, if we misgender someone, so call somebody by the wrong pronoun, if we label them with the wrong gender, that can actually be a source of trauma. And so going back to Glenn's discussion around ethics, we have an ethical code of conduct to treat trans folks in a way that's non-harmful. I really appreciate people's commentary on this because I agree with you. I think stigma is huge in the lines of work that we do, and I also think that by addressing stigma, we can actually work ourselves out of a job, because really, stigma is often the cause of a lot of STBBIs. So we'll move on now. What I want to do is take some time to really examine our personal practices. I know that when we're in the day-to-day, it can be difficult to have these privileged moments to sit back and really think about what we do. What are our organizational policies? What is the kind of language that we've just become complicit in using because it's common, right? So we're going to really take a few minutes now to reflect. So I think we've talked about this quite a bit, but I'm going to give you all about 30 seconds to just think to yourself, what are some of the common challenges related to stigma, STBBI, sexual health, and substance use that comes up in your practice? So I'm hoping that all of you were able to take a moment to think about it. What I would like now is Rachel is going to put up another poll. And the poll that she's putting up is which area of stigma do we think it might be easiest to address within our personal practice? So internalized stigma, perceived, enacted, institutional or structural, layered or compounded. Oh, Laura, that's okay. Don't worry. Thanks for coming. We love folks from Vancouver Island. Okay. This is really interesting. So we're pretty split at the moment. I'm just going to give people another maybe few seconds to vote on the polls about which area of stigma you think it might be easiest to address. And Caitlin, I think you're right. I think that a lot of times language is really important, and that if we use proper plain language that people can understand, then we're able to really, I think, start challenging stigma. So if somebody hears me cutting out, I apologize. I'm not sure what that might be. It may be because I'm giving a lot of time for pauses for people to think. Hopefully, though, the sound is not bad for people. If you're having problems, remember, you can directly chat with CPHA Webinars or Rachel McLean, and she can help them. She can help you. Okay. Overt stigma and discrimination seem the easiest to address because they are easy to name. Microaggressions are a huge challenge. So, Wes, I think you're right. I think that's a really, really important thing to bring up. So a lot of people are saying perceived stigma or institutional or structural stigma seem to be the easiest ones to address. I think that that's true. And as we move on, I think we'll look at some of the different ways in which we can do that. So Rachel, do you mind just closing the poll? Yes, so the stigma we don't see is the most dangerous. And I think that that's really important. I think that's a really, really, really important thing to bring up. So what we're going to do now is we're going to look at each level of stigma, and as a group we're going to talk about some potential interventions and how we see this coming up. So we're going to start with internalized stigma. So first of all, what are some examples, or how do we see internalized stigma happening in the work that we do with people? I'm going to give you a little bit of time to do that. Yes, so Laura's bringing up a really good point around ingrained or assumed cultural norms, and so how that can be very, very difficult for people to address that. For the rest of us, maybe let's start with some ideas around internalized stigma. Okay, excellent. So Wes, this is so important. It manifests as shame. People who do not think they deserve good health do not seek to achieve or maintain it. Excellent. Not excellent that that happens, but that's a perfect example. Caitlin, lacking the confidence/capacity to advocate for oneself. This is really important, and I think we can see that on several levels. So we can see that where clients might not feel they can negotiate safer sex practices with their partners because of internalized stigma. They may feel like, you're right, Julie, like they can't come for help because they don't deserve it, and so they may hide any kind of behaviors from professionals. Self-deprecating, aren't able to stand up for themselves. Yeah, I would agree. This is what we see very commonly. I think one of the areas where internalized stigma also comes up is when folks maybe are they contract a STBBI, and then maybe they feel as if they can't have healthy, loving sexual relationships after. Like it has to change their their lives significantly, which is really horrible. Resiliency building oh good. Okay, so for strategies, Lisa Clark is bringing up something really great. So resiliency building programs or strategies, I think that's good. Building personal capacity and confidence, positive things that the individual has to contribute. This is excellent. And I think you're right, it can make it difficult for people to trust healthcare providers. So a couple of the strategies that people are coming up with I think are really important. So empowering folks. We do a lot of work here at Calgary Sexual Health Center around engaging communities to really work towards addressing internalized stigma by recognizing where it comes from and creating their own path to the services that they need. So a lot of community impact. So here are some of the examples that many of you brought up. And one of the key things that I want to really bring to everybody's attention is ensuring that our own interactions with clients do not perpetuate stigma, but rather empower people. So some of the things that people have talked about is inclusive language. So asking about partners, ensuring that we're using correct pronouns for people, ensuring that we're asking people if they, what type of language they want to use, being very open to people's different types of relationships, asking all people about substance use, not just people that we might traditionally consider using substances. I think this is really important too, that we involve people accessing services in the development of programming as well as health promotion campaigns. Sometimes health promotion campaigns can actually be highly stigmatizing, particularly if they're targeted towards a specific group. And so it's really important that people are involved in the creation of services so that they have a voice. And they're able to say, actually, when I look at this, this is how it makes me feel belonging to that particular group. Okay, so we're going to move on to perceived stigma. So what are some of the ways in which we see perceived stigma coming up in our work? And I'll just give you a minute to type some things out here. Okay, great. Access to services. Oh, yes. People assuming that needle exchange clients are dangerous. People have trouble accessing. So a lot of people are talking about how perceived stigma is going to create barriers for people feeling comfortable to come in and access services that they might desire. People assuming we are not sex positive. So that's super interesting, Julie. Yeah, I think sometimes people assume that if they're going to go and talk to a professional about their sexual health, that they will actually experience non-sex positive, so shaming attitudes around sexual activity, maybe that we're not going to be open to talking about substance use. Yeah, I think Jillian or Gillian really kind of echoes that same thing. So this is really great. So Cheryl says, helping the individual to understand stigma can arise from fear of the unknown and the importance of providing meaningful, practical information. That's great. So I'd like to move on. What are some strategies or things that people do within your own practice to help confront and challenge perceived stigma? Oh, this is good. So the continued impact of colonization and the results of this on our First Nations clients seeking care. I think this is really important in that people recognize that not only does this statement around colonization also is part of perceived stigma, but also compounded stigma, right? It's that intersectionality of identity. So what are some things that you're doing? Lots of you are typing, so I apologize for those of you who aren't engaged in the typing and you're more just listening, but I really, really do want to get this information from the group. So that's great. So checking out our own biases. It absolutely starts within us, right? We need to recognize when something is challenging our own personal values and biases. We all grow up in this world, in this society, and I think we're constantly unlearning the things that we've been taught. So it's really good to consider your own values, being aware of your own thoughts. Excellent. So here are some of the examples that we came up with based on some of the literature and key informant interviews that CPHA did. Laura is talking about having harm reduction-friendly signage open and visible in all of our common areas so that we aren't setting a tone that it's only for some people. I think that's a really important piece of information. We need to challenge our own personal perception of who uses substances and make sure that this stuff is available for everybody. I think that's an excellent example, Laura. I really love that you brought that up. Reflection on our actions and the manner in which we address others. I think that's really important. People are very attuned to our nonverbal behavior and to the type of language that we use. So individuals who feel like they may receive stigma from a service, they're going to be hyper aware. And it's up to us as service providers. It's actually our ethical responsibility to ensure that we are working in a way that allows people to know that it's a safe service. Creating tools to help healthcare providers initiate conversations when they've been traditionally uncomfortable to do so, like with STBBIs. So Pamela, it's as if I just paid you to say that. The Canadian Public Health Association has created a really excellent document and tool for folks around talking about STBBIs and substance use. And it's actually a discussion guide that's been created with many, many, many service providers. There's a really excellent literature review done beforehand, so it's very evidence-based and best practice. This is currently still in draft format, but at the end I'll give you information on how to connect with Rachel so that we can disseminate this information for all folks. One of the things I want people to take a moment and think about, and actually we're going to use the thumbs up or the thumbs down from the little person up at the top, so we can do the agree or the disagree. Those are those two things kind of in the top corner of your screen. Basically give a check mark if you hear the word risk used a lot in your professional practice. Maybe not by yourself, but by the people around you. So I'm just going to be looking at your, there we go, Keely, hands up. We could do the hands up too. If you hear the word risk often, you can give me a hands up or a check mark. Melissa, yep. There we go. Lots of folks are saying that you hear the word risk being used. Tons of you, yeah. So a lot of you are still commenting on if you see risk, and I think that's really important. Let's see. Okay, so, you know, a really strong percentage of you are saying, yes, risk language is very common in the way that we engage, even the way we're taught, right? If you think back to when you were in university, we talk about risk very often. Now, what's the problem with the word risk? So I'm going to let you just type one word. When you hear the word risk, what is the word you think of? We're all just typing one word now. When you hear the word risk, irresponsible, harms, yep. Danger, 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 fear, danger, scary, prejudgment, danger, fear, harmful, reckless, yeah. Irresponsible, non-thinking, bad choice, stay away, yeah. So thank you very much for helping me kind of unpack this idea of risk. So risk is something that is very dominant in our public health discourse. And I would really encourage people to think back when we use the word risk with an individual who is looking for and is hyper aware of the potential of stigma. These are the words they might be hearing. So when someone says, lower risk behaviors, what they might actually be hearing is less reckless, less irresponsible, less of a bad choice, right? And I think that can really perpetuate perceived stigma. So one of the tricks that I've been trying to use in my practice is trying to say things like behaviors, right? They're all just behaviors. Laura's made a really good comment here. We also include all staff in harm reduction education and cultural safety education. I love that you said cultural safety. Nurses, management, front-end reception, and admin staff, so that we are all on the same page at all levels. We even talked about harm reduction as negative and stigmatizing. And really what we are working on is health promotion. This is amazing for everyone, regardless of their life circumstances. So Laura, I think what you're talking about is a really fulsome approach to challenging perceived stigma. I love that you've brought this forward. It's about training everyone so we're on the same page, because the person at your reception, they can really set a tone, right? It goes from every single person in your agency. This is really good too. When providing information about substance misuse to elementary students, we risk creating perceived stigma amongst these youths with families that are at risk. So Lisa, this is so important, and I love that you just brought this up. We can actually alienate the students that are in classes, right? Oftentimes when we're doing health education or health promotion, we need to be super cognizant around what kind of comments we're making, because totally you can be alienating whole families. So I'm really sorry for those of you who are losing the audio. I again, chat with the CPHA person, people to try to help you out with that. I'm really enjoying, though, the folks who are typing and bringing information forward. You're bringing a lot of good stuff. So we're going to move on now. Here's some of the strategies. So we've talked about quite a bit of this. Really think about the word risk and how you can not bring that up. Make sure when you're asking your clients questions, they're open-ended and necessary. One of the things I like to do is, before I ask someone a question, think about how would I feel if this question was asked of me? Is it important? Is it necessary? Is it relevant to the conversation that we're having? One of the things I strongly encourage all professionals to do is bring up substance use and sexuality with everyone, regardless of if we assume they're part of a group that might be engaging in sexual behaviors or engaging with substance use. It's really important that we challenge our notions of who would be benefiting from information about sexuality and substance use. And again, it's really important that we use clear, plain, and inclusive language. So really try not to use the jargon that we love in our practices. Okay. I think enacted stigma is something that we've probably all seen. So if I could just get a sentence or two of what can happen when we see enacted stigma, or what maybe people have seen within their practices. So I'm going to give you a couple of minutes just to. So sometimes the folks that we work with might feel like they're less worthy of the same care that non-stigmatized, non-traditionally marginalized groups take for granted. I think that's really true. I used to work in a harm reduction program that did housing first for people who are experiencing addiction and some chronic health issues. And going with folks to access services at the hospital, you could actually see this massive, real, outward, obvious stigma and discrimination. That had it just been myself going to get those same services, that wouldn't have happened. So I think that's really a really important thing to think about. Oh, this is interesting. When we present data that isolates a particular group and shines a negative lens on this at-risk group. So, Lisa, I really like that you're bringing that up. I think that that's true. When we talk about things like, and you can hear it in the language, vulnerable populations, right, or at-risk groups, even that language is quite stigmatizing, and there's a tension there to talk about how the social determinants of health will perhaps place people at greater risk to experiencing certain health outcomes, but also being empowering in our language. Yeah, so this is great. If you don't have an address, you can't get government financial assistance like Ontario works. And I think that's very true with, I know certainly in Alberta as well. We can see that there are certain specific things that are set up in our society in order for people to access service. So is there any strategies that people would like to put up in the text box? If you want to, I'm going to also flip over to some of the strategies that we put up. So again, some examples that we came up with is that service providers can actually cause trauma if they're not aware of the potential impact of their languages, of the language. Services that exclude people based on their identity, services that are not created or delivered in a manner that is inclusive and welcoming to all clients. So some strategies that actually came up earlier from Laura is engaging in regular staff training. So again, it's really important involving different client groups in the development and implementation of programming and health promotion campaigns. Ensure that you're working from a trauma-informed perspective and be really cognizant of the impact that your language can have and recognizing the importance of employing a trauma-informed lens. Also, reviewing organizational policies. So this is really important. Yeah, understanding the community you work with through inclusion and consultation and program development, right? I think that's key for people to really have services that make sense for them. Just because we're kind of starting to run a little quick on time, I am going to let people think about layered or compounded stigma, and this one I think can be quite difficult. So I'm going to give you maybe about 40 seconds. If you could just type how you see layered or compounded stigma impacting the people you work with. And some people have already brought this up, so just maybe quickly, people want to type something. Thanks, Amy. Shelley, that's great. Lots of people are typing now. That's wonderful. Yeah, so people who are experiencing layered or compounded stigma, one of the things that Linda said is exclusion instead of inclusion. And I want to talk about how I've personally seen this manifest. So a person who is living with HIV, maybe not feeling comfortable going to the local HIV serving organization because they're also part of another stigmatized group, and they don't see themselves actually as being a part of that particular community. And so then when people are accessing services, for one part of their identity, they may actually feel excluded from that very same service based on another part, right? Allowing the community to exercise its agency. So I think that's a really good strategy, right, to deal with layered or compounded stigma. I have a question. How do we complete government documents when we are required to identify certain risk behaviors, i.e. HIV testing? I think that that's a really important point to bring up, Amy. And I think one of the things that's happened here in Alberta that's really amazing is the Positive Voices, I believe that's what they're called. They're through our ACCH community, and it's people living with, and they've done a great deal of advocacy so that the requisitions for HIV testing no longer force you to identify which, and I'm using air quotes right now, but you can't see this, which risk group you belong to. So physicians are no longer forcing people to disclose around ideas of like, oh yes, so this is the reason why I have to get HIV testing. So what I'll say is that it can be around advocacy, right? Completing a lot of government documents where maybe they are stigmatizing, advocate for change on those. And if you can't do that because you're within a system where you can't advocate at this point, I would suggest actually saying to the individuals, like, I recognize that this sounds really bad and I'm doing this because I have to. Does that make sense, Amy? Please elaborate with an example of layered or compounded stigma. So I think that's great. So I just switched over to an example. So when individuals concurrently experience stigma for different elements of their identity, they may experience additional barriers in disclosing information about their sexuality, end substance use and accessing the information that they need. So for example, if a person, maybe an Indigenous person who is, I think, experiencing a lot of impacts of colonization, tries to access services, and they're also living with HIV, they're going to be experiencing perhaps stigma on both different levels, if that makes sense. So it's multiple elements of a person's identity that's experiencing stigma. And clients might not feel safe accessing services if they do not see their identities welcome in that space. So some of the strategies that we've identified for this is being conscious and aware of, again, your own attitudes, values, and beliefs. Be intentional and aware of the impact of intersecting sources of stigma and oppression. And finally, advocate for safer and inclusive spaces for clients. We're just going to move on. Another person is typing, but we'll grab their comments in a second. And this is one of the areas where people felt like there could be a lot of change made. So institutional or structural stigma. I'm going to give you a couple of seconds just to think about the different ways in which we see institutional or structural stigma, and then we're going to brainstorm together some strategies. So a few people are already typing. That's awesome. So many of you are typing. That's great. I'm just going to give you another little bit of time to get your thoughts out there. And for those of you who aren't typing but are just being patient and listening, thank you so much. Okay, so this is great. So lots of good information. So location of our offices, the hours we're open, no evening or weekend hours. I love, Julie, how you brought that up because sometimes own environments or spaces or policies can actually perpetuate structural stigma. So if we're creating services that are best for the employee as opposed to the client, that's probably a problem. So structural stigma that marginalizes whole groups. Sean, this is a really important point. So not having gender-neutral or gender-inclusive bathrooms, intake forms that force people to identify within a gender binary, so as either male or female. I think that can send a really strong tone. In lots of different ways, most of our society is actually based on male or female bathrooms, right, which puts people who are trans or might identify as gender neutral for fear of experiencing violence in public spaces. Shauna is saying, individuals in my practice who are trans or non-binary can't change their gender on their documentation until they have a health card that reflects their gender due to billing purposes. This creates all sorts of issues with misgendering and assumptions. Shauna, thank you for sharing that. I think that's really important. And I'd actually like for people just to take 2 seconds and think about how many times a day you use your identification, right? Or how many times a day we need to make choices based on our gender identity. And a person can see how there's so many structures in our society that can be creating a ton of stigma around gender. Cheryl's talking about inclusive policies, so I think that's really important when we start looking at strategies. So does anybody want to talk about some strategies that maybe their agency has taken up in order to address structural or institutional stigma? I'll give you a couple seconds if you want to type up potential strategies. And I'll also put that slide up there. So one of the things that I think came up, and it came up really clear in the literature that was reviewed in the creation of the discussion guide for talking about substance use and sexuality, is this idea of working in under-resourced settings. So professionals actually not having the time to have really great, rich conversations with clients about sexuality or substance use. People being on the clock in terms of getting individuals in and out. One of the things that a lot of STI testing centers say is that they have really long wait lists. And so clients might feel like they actually don't have 4 hours to wait for testing, so they may not get tested. A really huge example that typically comes up is the criminalization of HIV non-disclosure. Right? Privacy and confidentiality issues, and then again, what was already brought up, I think Julie brought it up, is our organizational policies. So Cheryl's talking about raising public awareness as a key issue. I think that's really very true. Here are some of the strategies that we came up with. So the environment for discussions about sexuality or substance use should be private. And I know sometimes just based on office spaces or how your layout is of the space, that's very difficult to create. And I would say advocate for that. Right up at the front when you're talking to clients, talk about confidentiality. Privacy and confidentiality should be respected. And so recognizing that if you're working particularly at an ASO and you let somebody else know within the service realm that you're seeing a particular client, you could potentially be disclosing a person's HIV status, right, or their STBBI status. So it's really important to be very careful of even slight slips of confidentiality. Also remember that your records can be used within the legal system, so it's really good to keep your records to a minimum, yet in accordance of your professional practice obligations, right? And advocate for change. If you're living in a small community, it's actually okay to advocate for services that you maybe need, or look for non-traditional areas of support, right? So online resources. There's a ton of national organizations that can provide support to folks. I have two more people typing. Oh, this is good. I think this relates to layered or institutional stigma. So First Nation people also may feel stigmatized if they live on or off reserve, have status or non-status when trying to access medications or publicly funded health care because they often have to navigate between federally or provincially funded coverage. Some things are covered and others are not. Further, the general population have really negative misconceptions about social funding for First Nations people. This is a huge barrier to equitable service. As a solution, health and social work professionals need to be educated in how people access services. So Laura, that's really, really an excellent example, and I think you can actually see the stigma model layered over top of that example in so many different ways. Robin, the slides will definitely be available following this, and Cheryl, I'm really sorry about the audio. Okay. So regardless of the situation, or regardless of the way in which stigma is manifesting itself, it's really important to start with ourselves. We can't always be working in spaces that are totally safe, but we can guarantee that we are a safe professional, and that really starts with considering our own attitudes, values, and beliefs about substance use, sexuality, gender, all of these things. So anytime something comes up, I encourage people to pause and consider your initial reactions. Think about what your values are. Are these initial reactions related to unconsciously learned beliefs or values about certain groups of people? What is my body language communicating? And then again, going back to your professional responsibilities to that person, right? So it's really, I think it's really important because it starts with us. So one of the things that are inside of the discussion guide that I just want to talk about, and it came up really clearly through several of the key informants, to look at the 5 Ps when it relates to talking about substance use and sexuality. So starting with partners. So when we talk to folks, a non-stigmatizing way to talk about partners that I really like is, where have you met your partners? So some people might ask questions about, are you currently sexually active? Have you ever been sexually active? Who are your partners, male, female, trans, two-spirit? Have you ever had sexual partners who you think are? So I think that you'll know with a client different ways or easier ways to have these conversations. But I really like the idea of where have you met your partners. That will allow that person to really disclose. The second things you want to talk about is practices. So one of the things that they suggest is, asking people to first, setting the groundwork saying, I'm going to ask you more detail about the kind of sex you've had, right? And the kind of substances you use. We ask all people this. One of the things that I'll suggest is be really careful about the language that you're using here. Make sure that that language is inclusive to the person that you're working with and allow them to really guide that. Then you're going to want to ensure that you're touching on protection from STBBIs, right? So some strategies around barriers. You're going to be talking about different harm reduction methods. If you're talking about substance use with that person, you're going to want to be really getting into the conversation about, health promotion. Finally, you're going to want to ensure you're touching on past history of STBBIs, particularly if a person is living with an STBBI that could potentially lead them at risk to contracting another STBBI. And one of the ones that I know in my personal practice I sometimes forget is to talk about pregnancy and to make sure that we talk about pregnancy in a way that's really inclusive. So actually asking everybody about pregnancy and not saying, unplanned pregnancy, not putting any shame around the idea of pregnancy. So just say, are you considering pregnancy in the future? What are your thoughts around pregnancy? So making sure that those points are there. So we think, and I think CPHA certainly knows through their literature review and through their conversations with key informants, that to have a really fulsome, good discussion around substance use and sexuality, we want to be touching on these 5 Ps. Now, clearly we're not always going to be able to have these conversations in every situation, but to kind of keep them in the back of your head, that these are areas that we might want to be discussing with folks. Okay, so what I'm going to do now is open it up to any kind of questions that people might have. You can ask a question directly to me, or you can put a question out there to the group. So I'm going to give people a couple of minutes just to think about some questions they might have, or strategies or thoughts that came up through this discussion that, can I see all the slides in the screen? Yes, so we'll be sending back, it is possible for people to be getting all of the slides after this is done. Oh, you joined late because of computer issues. That's totally fine. You can contact CPHA and you'll be able to get the link for the recording. Oh, this is nice. No worries, Becky. I've really enjoyed participating in the forum, and I thought the presentation brought up many interesting points for discussion. Many thanks. Well, thank you, Cheryl. That's lovely. Are there good online education for healthcare providers available? So, Maureen, I think that's an excellent question. One of the things that we're looking at is putting our first Stigma 101 presentation up online, and that should be available within the next couple of months, and you will be able to access that directly through CPHA. There is a few other things that have come up, but we're really looking at creating some more information in the future. Thanks, Nadia. Does anybody else have any questions or comments? Does anybody else know of any other good healthcare online tools that they want to share right now? Because that would be really great as well. Great. So Rainbow Health Ontario has some excellent training tools and resources on LGBTQ healthcare provision. That's awesome. Thank you very much, Shauna. That's true. I really love a lot of what they do, and many of the resources that we use in our work here at Calgary Sexual Health Center certainly come from there. Action Canada for Sexual Health, Chart Your Parts, has a ton of resources for service providers. That's great. Calgary Sexual Health Center, our website is pretty large, and we have a lot of information as well. We do not currently offer online training, but there is a ton of information on there. Christy, so strategies. At our health unit, we take our services, NEP, STI, testing, vaccination, to community centers that support priority population. That's great. So I love that you bring that up, Christy, is bringing our services out to communities as opposed to forcing people to come in to see us. I think that's really important. CDC has a good sexual health history taking online. This is awesome. Thanks, Wes. Great. Okay. So if people don't have any other questions or comments, there's a couple things happening. And I think Rachel's typing up some information as well. Yes, thanks, Rachel. So please, everybody, remember to complete the evaluation survey. You can see the link right there for fluid surveys. Because this is a bit of a non-traditional webinar, I'm very, very interested in hearing what your thoughts are about the chat and what you took out of this. I personally loved spending this hour with you, with people all across the country. I think it's really neat how we can use technology to learn from each other. And I love how there's a lot of... Thank you all so much. Please fill out the evaluations. I'll be hanging out online for another minute or two. If anybody wants to give some comments or say anything, that would be great. And feel free to email me or Rachel McLean. You can see our email addresses above if you have any further questions or comments. So thank you again.